We are the home stretch of our show for today, the 4th of July 2024. It's a Thursday. Yauda. Good morning to our friends listening to us in Osekrum, Kumasi, the guys and girls at Ahujo, Las Vegas. Also, all those listening to us in Tamale, of course, in Cape Coast as well. Well, it's time for us to now talk about your health. Your health. On Health Today. Last week, we brought you a conversation about something very important. Tumors, but specifically in your brains. And we had the privilege of Dr. Teddy Totimeh teasing us with a number of things as far as what is even considered a tumor and what is not a tumor. How do tumors present? And what kinds of impact do they have on us? He introduced us to two types of brain tumors. One type, the prognosis is very grim because as far as science has advanced as it stands, nothing can be done about it. They'll just tell you the number of days or weeks or months you are left to go away. But the other, there's some hope in there which can be dealt with when using surgical procedure. Dr. Totimeh joins us today again to bring us the second part of this conversation. Doc, you're welcome to the Asaase Breakfast Show.
Thank you very much.
It's good to see you.
Yeah, good to see you.
And Doc has come in his full regalia, his scraps. Yes. You know, recently I've been watching this medical TV series, New Amsterdam.
Okay.
Yeah, and
it's a good show.
It's a good one, yeah.
It's a good show.
The medical director is just, how can we help?
Exactly.
How can he's
Exactly.
always about what
Yeah.
how we can do to help.
You see how he gets into trouble.
A lot, you know. And so today on my word of inspiration, positive mental attitude, I spoke on the subject, learn to say no also.
Okay.
Because that guy is always saying yes. He's always saying yes. And it's always getting into trouble. Always getting into trouble. Anyway.
But he has a lot of impact.
A lot. I mean, a lot. And it affects other parts of his personal life.
Exactly.
You know, it comes with it. Giving yourself to everybody else but yourself.
Exactly.
Brain tumor. And last week, as I did indicate, you've already explain what it is for the benefit of those who were not able to tune in last week. If you just give us a quick summary of the various aspects that we touched on last week.
Okay, so I think it's just important to note these points. First of all, that every cell in the body obeys a certain set of rules. A set of rules is determined by the DNA that we have, right? So if the cells obey the rules, then everything is fine. When the cells do not obey these rules, then we have a problem. So a tumor cell is a cell that has stopped obeying the rules according to DNA. So a tumor can happen anywhere in the body, and especially in the brain. I was saying that we tend to see it for growing children because they are the ones who are having development going on in the brain. And then we also tend to see it in the elderly because in order for DNA mistakes to happen and for them to show in the body, you have to accumulate a number of mistakes, right? Because the body generally has its own editing mechanisms. But when these mistakes overwhelm the editing mechanisms, then you have the tumor showing. And so we also talked about the fact that these cells which have disobeyed the rules can either disobey it in a benign manner where they're just increasing in number and occupying some space, And in that case, the symptoms come because they are occupying space, right? But then there's also those who obey it in the malignant, they disobey in the malignant manner, where it's not that they're just occupying space, but they are also causing severe reaction in the surrounding cells. So these ones would be malignant, right? So of the two, generally, the benign tumors and the malignant tumors tend to present, the malignant tumors are fewer than the benign tumors. However, when it comes to children, we tend to have a closer mix, where because the cells are developing, you have quite a number of benign and then quite a number of malignant. In the adults, because the tumors would generally tend to be an accumulation of mistakes, we tend to see more malignant tumors than benign.
Okay.
Yeah.
So that's a quick wrap. That was fast. That's good. And now focusing a bit more on the malignant, and just to give us better understanding of how it results through that route of malignance as opposed to being benign. What tends to be the kind of disobedience coefficient that results in malignance as opposed to going benign?
Yeah, I like that. That's a question that research continues to analyze, and these answers. It's at the moment, research into brain tumors is like that old story we have of an elephant and blind people touching various places and saying, right. So we're still researching, we're still finding out, but the story is becoming clearer the more research is going on. For some reason, it seems like there are various growth patterns that the cells are supposed to go through, and there are various how do I put it, checkpoints that at every stage this is what the cell is supposed to do. For some reason, for some kind of tumor, some checkpoints are removed, and then the cell just goes through at high speed without slowing down, and that's what ends up causing the tumor. We've gotten to the point where we no longer look at the tumor under the microscope as the key way of diagnosing it.
That's how it looks.
Yes. Initially we would look under the microscope. I mean, we still look under the microscope, but it's more like complementary to the main way. So the main way is going to the DNA and finding out what checkpoints were removed, what accumulation of mistakes have been made, and then give it a genetic name. And in that way, then we know we have diagnosed.
Okay. So now what you're saying is, when it comes to your diagnosis, it's more from the genes point as opposed to the appearance point.
Yes, because without knowing what's happening at the gene position, we don't know what is causing the tumor. And all you'll be doing is just putting out a fire without knowing what is causing the fire. Right?
It's like doing symptomatic diagnosis.
Exactly.
Instead of going to the lab.
Going to the lab and finding the cause. But in Ghana, most of our genetic diagnosis is done in South Africa.
So what you're saying is we don't have enough facilities here in this country to do the genetic diagnosis.
We don't. It is now that slowly we're beginning to get the capacity. But the key, way in which you get genetic diagnosis in Ghana at the moment is it goes to South Africa and comes back. Right.
What's the most advancement that has been made, especially when it comes to the malignant tumor, the research? What's the best that research has shown so far?
The best that the research has shown so far is the fact that by designing molecules that you can target specific checkpoints that have been, overcome by the tumor, you can actually slow it down. You can actually slow down
the spread. Okay.
And you can actually slow down the progression of the tumor and add a few more
days or weeks or months.
Months.
Okay.
Yes. So unfortunately, we're still at the point where, in spite of all the research that has been done, we're still getting maybe 3 or 4 months in addition to, what would be without the treatment. So that is how dire the situation is in malignant tumor, right? At the best centers, you're adding a few more months. If you get a few years, it's a blessing. We're adding a few more months. But we always say that, the research that is going into gaining those few more months is crucial, because we learn a lot of lessons that we can stand on for further work. Now, none of that research is happening in the country at the moment, because our capacity to really look at these things happening at the molecular level is very limited. Yeah,
that's some way.
Well, I mean, there are a few organizations. I mean, one organization is called Nyamache. It's a private venture organization which is doing some work, has secured some grants from outside the country to do that kind of work. But having local capacity that enables us to look at these things and talk about them. And the thing is, a lot of this work has been done in the high end countries, right? The high income countries, right? But all people in the world came out from Africa to the rest of the world. So if you're looking at genetic code, I mean, you can say that the chapters of the genetic code are in the various countries, but the actual book is in Africa, right? So they could be looking at the legs, the fingers, the toes of the elephants, but we have the main core of the elephant in Africa, and the capacity to look into it doesn't exist.
What's the prevalence of these brain tumors, especially on the Africa continent, relative to the rest of the world?
So, Africa made the shift from communicable disease. We talked about
yes,
to non-communicable disease. We made the shift about, depending on which country, about 20 to 30 years ago. And slowly these non-communicable diseases have been, right? Now, of the non-communicable diseases, brain tumors are causing about 4 million deaths in Africa per year. Just,
4 million.
4 million, right? And the truth is that, the way things are going, by 2030, 70% of brain tumor deaths will be in Africa. 2030. Right.
Chairman.
No, but remember, remember that, first of all, the research is not happening here. We're not developing the medications for it here. We're not developing the surgical capacity to deal with the problem quickly enough, right? This country has 27 neurosurgeons, right? Okay, for 36 million people, right? Okay, so, and we don't have the capacity for genetic analysis, apart from small research institutions which are doing it. If I want my tumor typified today, I need to send it to
South Africa
for it to be done, right? And then our general care that is supposed to pick these things up early so they can do something about it is also not, So because of that, and then we're growing, continents. We're very young, so a lot of children, that's a lot of brain tumor. And then we're also surviving longer, right? Ghana is currently the per capita. It has the largest number of over 70 years for West Africa.
West Africa,
yes,
okay.
Right.
That's some good news.
That's some good news, right. But Exactly. It means that people are accumulating, the mistakes.
Yeah.
And then are more likely to get brain tumors. So it's their challenges, right? But the key thing, if I was asked what should we do, is to look at research.
Yeah.
Right. Because we can't use the research that they're using to deal with our problems.
Especially when they didn't test them
exactly
with us.
Right. Because our genetic makeup might
significantly
be
different,
much more diverse than, right?
So that's with all the bad news side.
Yes.
And I'll come to okay, Nane, let me introduce you in here.
I just wanted to ask, in relation to the research, you spoke about South Africa being the go-to destination. Is there nowhere else within West Africa that is progressing the research? Senegal, Nigeria?
No. Well, Nigeria has some small spots where it's doing, right, this kind of work. But again, it's in small research places.
Privately owned.
Right. But the truth is, for sub-Saharan Africa, most of the research and high-end work is being done in South Africa. Right. And South Africa has all the data centers for sub-Saharan Africa, and in terms of let me talk about Ghana for development that have happened over the last 50 years. 50 years ago, we didn't have imaging, right? Okay, now we have imaging.
We didn't even have X-ray.
We didn't have X-ray. We had X-rays 50 years, yes, but we didn't have CT scan and MRI, right? So CT scan and MRI started about 30 years ago in Ghana, right? Now we have CTs and MRIs all over the place, so we can actually diagnose, right? Okay. Now, once we diagnose, what do? We need to be in the hospital for surgeons to have a look and then have a plan for taking it out, right? Okay. Now, those surgeons are not enough.
27.
Right. So, and the way in which these brain tumors present is the fact that we said it was about space. So they compete for space, and then they start pushing against the normal brain. And so the person starts showing either a defect of where the brain is controlling, right? Okay. But the key thing is usually headaches. Headaches, not because the brain doesn't have pain receptors, right? So if I put a knife in your brain, you wouldn't feel it.
Oh, really?
However, there's an envelope around the brain, and as it stretches, it causes pain. Right? So because the tumor is competing for space with the brain, the envelope stretches, and then you have headaches. So we say that for people who have had headaches for more than a month, a CT scan is mandatory because it could be a brain tumor, right?
Wow.
In our environment, it might not be, but if a headache has been continuous for more than a month, CT scan, right, or MRI, right?
And this is a very important message. I mean, I've been coughing for some days. No, but this, of course, I mean, more seriously,
right.
If you are experiencing any form of headache which has protracted
Yes.
for about a month
Right.
or more,
Right.
so it has been consistent for about a month or more, you need to get a CT
You need
scan.
to get a head CT scan.
But, before you do that, for such imaging, you would require a prescription from a health
Yes,
facility.
you do. So you need to be seen, at a hospital. You have to be examined. Your history has to be taken and things like that. The difficulty in our environment is that a lot of these headaches would have been treated as malaria. Person goes to the pharmacy, gets a medication, but the headache seems to settle down. So we get a lot of, late presentation. Right? So we're not picking these things up early enough, and they're coming when the tumor is really big, right? And the bigger the tumor, the more complicated the surgery, and then the lousier the outcome.
So, I mean, and just to rehash this, so if one has had headaches may be protracted for about a week, and then there's an intermittence of 2 days of relief, and it comes back again.
Once the headache is coming back, the person needs to be seen and needs some imaging. It's important. For most of them, the imaging will be unremarkable. It will be innocent, and we can treat for the other things. But for some, it might be what saves their lives. Yes.
And this, we now sitting within the benign region where something can actually be done about it.
Yes.
In terms of the surgeries that get to be done, does Ghana have the facilities for those?
We do. So in the teaching hospitals, we have neurosurgeons who are doing these brain tumor excisions. We have also this year, last year, the Ghana College of Physicians and Surgeons got a new faculty, which is the Faculty of Neurosurgery. Right. So
really?
So our new Faculty of Neurosurgery has made it such that we have residents in multiple hospitals.
Okay.
So these have become teaching centers. So in Accra, for example, Kolebu Teaching Hospital used to be the only teaching hospital, but now we have, for neurosurgery.
Yeah.
But now we have Kolebu, we have 37, we have Ridge Hospital, right? All being training centers.
UGMC is not part?
No, not yet.
Okay.
Right. But all being training centers for neurosurgeons, right?
Okay.
And then we also have up in the north, UDS. So Tamale Teaching Hospital has residents, and then we have Cape Coast Teaching Hospital Center, and then Kumasi, the Konfanoche, right?
Okay.
So these are centers where brain tumor surgery is done, right?
Okay.
Slowly, we've started doing brain tumors in the private sector, right? So brain tumors surgeries have been done at Focus. They've been done
Focus Hospital.
Yes, they've been done at Bank Hospital. They've been at Accra Medical Center, right? So these are new private areas where brain tumor surgery is being done, and then also at the Maritime Hospital, which is where, in Tema. So the good thing, the science has gotten in such that we now can do the imaging, see where the tumor is, have a plan for taking it out as safely as possible. Right? Now, what has happened in neurosurgery over the years, which has made things much, much better, is the fact that there's what we call neuronavigation, so that it is able to pinpoint exactly where the tumor is, and you can go to the tumor without much collateral damage, right? And then we also have the microscope, which enlarges what we are seeing, so that you're more exact in what you can take out. Right? And then, of course, critical care, both during the surgery and then after the surgery, has also improved. So the survival is better. It's just that now we also need to have additional treatment apart from the surgery. You need radiotherapy, where you're using rays to buzz the area around the tumor excision, right? And that is available
here in Ghana.
Yes.
So the radiotherapy, typically when we hear of radiotherapy, we are talking about cancers. Is it for the malignant ones or for the benign ones?
It's for both, actually.
Okay.
It's more for the malignant ones.
Okay.
The benign ones, generally, we can take everything out without leaving anything that radiotherapy needs to do something about.
Okay.
However, sometimes we cannot take the whole thing out, and then you might need radiotherapy.
Okay.
But radiotherapy would be more for the malignant one.
Is it possible to use radiotherapy for a not so grown benign tumor fully?
Yes. So it is possible to do radiotherapy without surgery.
Okay.
Sometimes the tumor has taken up so much space that surgery is just impossible, in which case then it's only radiotherapy and chemotherapy that can be used. Okay. But sometimes too, there are advanced forms of radiotherapy where you can just use that instead of surgery.
Okay.
Right.
Okay.
The question about radiotherapy has always been collateral damage. Right. So these
what else gets damaged?
Exactly. So the rays must get to the tumor by passing through normal tissue. Right. Okay. So if you're exposing the whole brain to powerful rays, and you don't have a way of directing the rays, then you have a lot of collateral damage.
Yeah.
Right? The difficulty in Ghana with our radiotherapy is that we haven't developed it to the point where we have what we call surgical radiotherapy,
Okay.
where you limit collateral damage. At the moment, there radiotherapy machines like called gamma knife, cyber knife. These are things that are very exact in where they shine the rays. There's none of that in Ghana at the
Like
moment.
missiles.
Yes.
Directly.
Like guided
boom,
missiles.
going
Yes.
straight, yeah.
And there's none of that in Ghana at the moment. However, I mean, in Ghana we have radiotherapy in Kolibri Teaching Hospital, Komfanoche, and then we also have one in the private sector, Sweden, Ghana.
Okay.
And they have, they've developed to the point where, they can give some guidance to the radiotherapy, but there's a lot more.
A lot more to it. Unfortunately, our time has run
Yes.
out. In 15 seconds, I don't know how you're going to manage that. You've mentioned the headache being one of the elements which will give you a sense, a prompter. But then you also mentioned that other receiving point where the brain is sending signals. So if a portion of the brain has become tumored,
Right.
the point where, what are the other symptoms which, or let me call them prompters for now, which should trigger somebody seeking help immediately?
Okay, so I'll just split into three.
Yeah.
For young
In
children.
15 seconds. Wow.
For young children,
Yeah.
if the head is getting bigger, right, we need to do something about it. If the walking is changing, right, in addition to the headaches, we need to do something about it. If there's vision problems, we need to do something about it. For the adults, it's mainly vision problems because in addition to the headaches, right, vision beginning to get worse or double vision or things like that. And then, of course, if you have weakness on one side or difficulty in walking, yes. But key thing, any headache more than a month, get imaged.
And the site, particularly because of where the optic nerves,
Exactly.
the location
I
relative
see
to
how
the
your
brain.
neuroanatomy is getting better. and better.
I'm getting
Keep
better.
it going.
I could watch you in a surgery.
Keep it going.
We've been talking to Dr. Teddy Totimeh. He is a paediatric neurosurgeon, and he's been teaching us everything about brain tumors and what we need to look out for and how we seek support as quickly as possible. It's been a very packed day on the Asaase Breakfast Show this morning. Working this with Nanaya Mensa and Kweku Inshirado. It's been a lot of things. My name is Benjamin Ofeado. Together we brought the Asaase Breakfast Show. We've had the pleasure of your company and we are very grateful. Do make a date. Join us same time tomorrow morning at 5:45 as we bring you another edition of the Asaase Breakfast Show.